Good afternoon to one and all present here. I'm Dr. Shobika, ER consultant from Saveetha Medical College and Hospital, and today I'll be taking you through the topic of difficult airway in the ER. So I'll be talking on a topic under these headings. First is incidence and what is a difficult airway, what qualifies as a difficult airway, and next will be the management in the non-emergency scenario and management in the force to act scenario, and also we'll be seeing some case scenarios to have more understanding. So these census are taken from the Near 3 project of USA and NAP4 census UK, and it goes on to say that when an emergency airway emergency develops, the odds of brain damage or death is 15-fold, and hence it is crucial to know that the management of a difficult airway So, when do you define a difficult airway? It is a clinical situation in which a conventionally trained anesthesiologist of more than 5 years experience has anticipated or unanticipated difficulty or failure to in either face mask ventilation is when an face mask ventilation or difficult or failed laryngoscopy, tracheal intubation, supraglottic airway placement, difficult or failed tracheal extubation, or difficult or failed invasive airway. When do you say it is a difficult or failed face mask ventilation? Is when an unassisted anesthesiologist is unable to maintain oxygen saturation of more than 90% using 100% oxygen and positive pressure mask ventilation. And when do you say it is a difficult or failed laryngoscopy? It is when you cannot visualize any part of the vocal cord that corresponds to your Cormack-Lehane grade of 4. And difficult or failed tracheal intubation is defined by the ASA task force as difficult tracheal intubation as occurring with proper intubation, where proper insertion of tracheal tube with conventional laryngoscopy is requiring more than 3 attempts or more than 10 minutes. When do you say as difficult or failed supraglottic airway ventilation? Is when inability to place the LMA in a satisfactory position despite 3 efforts and not able to achieve the adequate clinical ventilation tidal volume of more than 7 ml per kg. So now let's go into the airway approach to airway management in the ED. It can be a non-emergent scenario or a cardiac arrest or forced to act scenario. The non-emergent scenario is mostly not the case in our ER, but still this is when we do have some time to assess the patient, prepare the equipment and team, and go ahead for the airway management. On the other hand, cardiac arrest or forced to act scenario is when you have to act immediately to save the patient's life. So in non-emergent scenario, there can be anatomically difficult airway, physiological difficult airway, or situationally difficult airway. Anatomical difficult airway is when a physical abnormality that is hindering your vocal cord visualization, mask ventilation, or intubation, thus increasing your risk of obstruction and hypoxia. The physiological difficult airway is when there is the anatomy might be okay, but there will be more risk of cardiovascular collapse and arrest during or immediately during or after the airway during or immediately after the airway approach. That can cause hypoxemia, it be hypotension or shock, severe metabolic acidosis, or right ventricular failure. And when it is a situationally difficult airway, because like night duties, or when like the person is not skilled enough to perform certain procedures, or because of the time and place, that can make it situationally difficult. So coming to the non-emergent scenario, here, like I had mentioned, some time is available to assess the airway, and the second step is to identify whether it is anatomical or physiologically difficult. And meanwhile, we have to get started on the oxygenation, which is the pre and para oxygenation, to prolong the safe apnea time while we manipulate the airway, and also the checklist, which is going to help us in preparing the equipment, the personnel, and the plans that is going to be followed. And also then we can go ahead with either awake fiber optic intubation after airway preparation if it is very difficult, or you can directly go into the induction directly and then intubate. nearby. So non-emergent scenario. Like I had mentioned, in the non-emergent scenario, we do get some time to assess the airway and to identify whether it is anatomically or physiologically difficult, and also optimize the patient as such. And also, most crucial step is the pre and para oxygenation, which is going to prolong your safe apnea time while we manipulate the airway. And also, meanwhile, get started on the checklist where we prepare the patient, the position, the team, the personnel, the equipment, and also the plans. What do we move on to next if the plan A fails? And then we go ahead with awake fiber optic intubation after airway preparation, or go for induction directly. So to recognize an anatomically difficult airway, we can take the help of some mnemonics, which is going to help us to rule out quickly and save time. For difficult bag and mask ventilation, if patient has a beard, is obese, has no teeth, is an elderly patient, or has snoring or sleep apnea history, we might face difficulty with bag and mask ventilation. We might face difficulty in placing a supraglottic airway if patient has restricted mouth opening, there is any obstruction, distorted airway, or we might need to insufflate the patient with more pressure to make ventilation proper. So like in cases of ARDS, supraglottic airway device might not be a proper choice. We can use the most common mnemonic, that is lemon, where we have to look externally, which is a rapid visual inspection of the patient, and also evaluate the 332, that is the 3 fingers mouth opening, 3 fingers hyoid to mental, and 2 fingers hyoid to thyroid, and the Mallampati grading, which is on opening, asking the patient to open the mouth and assessing the grade 3 and grade 4, which corresponds to difficult airway and any obstruction or obesity and neck mobility. And when do we predict difficult cricothyroidotomy? That is when there is a recent surgery, recent like a mass, radiation scar, tumor, or any access or anatomical difficulty that we might face. And this is the intubation checklist. While first we have to prepare the team, we have to allocate the roles. Who is going to be the team leader, who is going to be the first intubator, who is going to be the expert intubator, who is going to help in the external laryngeal manipulation, the cricoid force, or the manual inline stabilization, who is going to note the time, which is very crucial, and also who do we call for help. And next thing, we have to prepare the patient as well. We have to optimize their position, and also if we are going to face any difficulty, we have to identify the cricothyroid membrane well in advance using ultrasound, and also we have to check whether they are optimized as well hemodynamically. And then we also have to prepare the equipment. For equipment, we can keep the mnemonic SOAP me, which is suction, oxygen, any airway adjuncts, position, mids and monitors, and the ETCO2 or equipment. So next is pre-oxygenation. So in preparation of airway, one crucial step, whether it is a non-emergent or a forced to act scenario, is oxygenating the patient to increase the safe apnea time. And this safe apnea time is going to delay the hypoxemia and give us precious more minutes in case the first attempt is taking time or has failed. So pre-oxygenation is nothing but removing the nitrogen completely and replacing it with 100% oxygen. And this can be done with a face mask, the HFNO, or a NIV, and in a head up position. So we ask the patient to breathe in 100% oxygen for 3 minutes at quiet breathing, which is nothing but the tidal volume breathing. Or we can ask them to take 4 deep breaths in 30 seconds if time doesn't permit, or 8 deep breaths in 1 minute, or 1 vital capacity breath to take in the 100% oxygen and wash out the nitrogen. And we can also add some pressure support or PEEP, like in cases of obesity. Apneic oxygenation or para-oxygenation is nothing but once you give the IV induction agent and patient goes into apnea, you deliver the oxygen to the nares or the upper airway, that is going to go passively to the lungs, and that is going to increase your safe apnea time. For this, you should have an oxygen source and a device that is going to deliver your oxygen, and also you have to have an upper airway which is patent. And also we should maintain adequate pre-oxygenation. And we should note that this is not going to prevent your hypoxemia. This is only going to delay. From the safe apnea time of 3 minutes, it might increase to 7 to 8 minutes. And it is not a rescue technique when the mask ventilation fails. How do we do para-oxygenation? The most common is NOSAD, that is nasal oxygen during effort securing a tube. This is by putting a nasal prongs at 15 liter per minute while you try to intubate the patient. And also you can also do direct pharyngeal insufflation using a nasopharyngeal catheter at 15 to 18 liter per minute, or a buccal oxygen delivery at 10 to 15 liter per minute. Or you can use a Thrive or HFNO if it is there, or you can also have invasive techniques like intratracheal endobronchial catheters as well. So for sake of completion, we are to handle the airway in ER, we should know about rapid sequence intubation, that is your classical RSI and a modified RSI. Classical RSI is when you put an NG tube earlier and empty the stomach contents and you pre-oxygenate, giving positive pressure adequately, and also you position the patient supine with a head down tilt, and also you induce with the IV induction agent thiopentone sodium, and rapidly acting muscle relaxant will be a succinylcholine, and you apply your cricoid pressure here, and laryngoscopy and intubation of trachea with a cuff tube immediately following the fasciculations. In a modified RSI, however, you remove the Riles tube and remove the cricoid pressure. Here the position is going to be a head up supine or ramped position, and here pre-oxygenation can be done but positive pressure is avoided. And here you can use any IV induction agent, be it propofol, ketamine, etomidate or thiopentone, and also here we use the rocuronium if you have Sugammadex available. And also here we will titrate the IV induction agent to loss of consciousness, clinical response as well as the hemodynamics. So now that you know how what are the prerequisites, now what will be your plan A, B, C, D when you tackle with and when you are presented with the difficult airway? And this is given by our difficult airway guidelines from AIDA, DAS, and ASA. This is going to help you in a timely and systematic manner that you, whenever you get into a fix, you know what is the plan that you should next resort. AIDA guidelines say that after planning, if you suspect a difficult laryngoscopy, difficult intubation, difficult face mask ventilation, or a supraglottic device placement, if there is an increased risk of aspiration or increased risk of rapid desaturation, you can go into the awake fiber optic bronchoscopic intubation. So here you will anesthetize the airway, so patient will be counseled and patient will not will not be uncomfortable with this, but also patient will be maintaining their airway tone as well as their protective airway reflexes. So this will ensure that patient never ends up into a cannot intubate, cannot oxygenate scenario, thus preventing any airway crisis. But if you are pretty confident that this is not going to be a difficult airway, then you can induce the patient with your IV induction agents and then go ahead for your airway management. The Difficult Airway Society 2025 DAS guidelines say that the plan A is tracheal intubation. If that fails, plan B will be a supraglottic airway device. Then plan C will be your final attempt at face mask ventilation. If despite this patient is not being able to, you cannot ventilate the patient, you should declare it as a CICO, which is a cannot intubate, cannot oxygenate scenario, and go for your plan D, that is your emergency front of neck access. So in plan A, tracheal intubation, you take a maximum of 3 attempts, and then 1 attempt will be by an expert personnel. And DAS clearly states that the first attempt should be by a video laryngoscope for highest first pass success. And you have to maintain adequate anesthesia and neuromuscular blockade and also be aware of the time passing by. If unsuccessful, you have to take the help of the airway assistant who is going to monitor your attempts and the elapsed time and is going to promptly provide you the equipment, whether it is changing the blade or the device or going to help you in providing the external laryngeal manipulation or remove the cricoid pressure if needed, and is going to help you with the position, or if needed going to go to plan B, preparing the supraglottic airway device. But once it is a failed intubation despite 3+1 attempts, you should ensure the ePhona kit is immediately accessible bedside. And going to plan B, supraglottic airway device placement, here we allow a maximum of 3 attempts, and here the DAS guidelines suggest second generation supraglottic airway device which protects against the aspiration, as well as has more seal, better seal will be more useful. And here also we have to ensure adequate neuromuscular blockade, and if unsuccessful we should try changing the size or alternate SAD. But once this fails, the ephona kit should be open, and you should go next to your face mask ventilation. And face mask ventilation final attempt will be done. You have to use the adjuncts poropharyngeal or nasopharyngeal airway, optimize the position, or go for the 2% technique, where 1% will hold the mask only to maintain the seal, whereas the assistant will bag the patient. And adequate depth of anesthesia should be maintained. If this doesn't work out, then this is an emergency, which is a cannot intubate, cannot oxygenate, and you move to your plan D, that is the emergency front of neck access. You take your scalpel 10, bougie, and ET tube size 6, and you put the patient in maximum neck extension with full neuromuscular blockade and suction available. You move forward with your scalpel cricothyroidotomy. First, you do a laryngeal handshake to identify the cricothyroid membrane, and you put, if it is a palpable cricothyroid membrane, you put a transverse stab incision, and you turn the blade 90 degrees with the sharp edge facing towards the feet, and then slide the bougie in, then railroad your lubricated cuffed tube into the trachea, inflate the cuff, and then confirm the position with your capnography. And if it is an impalpable cricothyroid membrane, you cannot put a transverse incision now. You have to make a large midline vertical incision, bluntly dissect with your fingers to separate the tissues, and you identify and stabilize the larynx and proceed with your with the above technique. So like I told you, the transverse incision changing to 90 degrees, and then putting the bougie in with railroading. Cardiac arrest or forced to act scenario, which is the more common scenario that we'll be faced with in the ER. Particularly, airway in cardiac arrest is not given in any AIDA or DAS or ASA guidelines. As per ACLS, the first step in airway management will always be your bag and mask ventilation, 30:2, which is 30 chest compression and 2 breaths, and you have to avoid hyperventilating the patient. But this, as given in the Brown Journal in 2022, it states that if bag and mask ventilation fails, you can go ahead with your intubation, or if your ROSC has been achieved and intubation is required for another reason, we can intubate, or if ROSC has not been achieved but still the efforts are prolonged, you can go for intubation, or if an experienced operator is available. And even here, the video laryngoscope should be preferred for higher first pass. Coming to some special scenarios, the first scenario is a 25-year-old male after road traffic accident with mid-face fractures, active oral bleeding, saturation of 90%, agitated on possible cervical spine injury. What are the challenges? Because of the facial fractures, there will be difficult mask ventilation. Because of oral bleeding, there will be blood obscuring view during laryngoscopy, and aspiration risk is there, and cervical spine precautions. Here, our plan should be rapid sequence intubation, but not just that, we should put 2 suction devices, a double suction technique or a salad technique. Salad is nothing but suction assisted laryngoscopy and airway decontamination. Here you insert a rigid suction yonker inside and clear the contamination and sweep the catheter to the side. You insert your laryngoscope and your endotracheal tube while parking the suction in the hypopharynx. So both takes place simultaneously. You have to use your video laryngoscope if blood is not excessive, or and clearly bougie should be ready, and manual inline stabilization, which I'll be telling on the next slide, for cervical spine precautions. If plan A fails, plan B supraglottic airway doesn't serve any purpose because it doesn't protect against aspiration and may not sit properly because of facial disruption. And bag and mask ventilation plan C is also difficult in this patients, so it might rapidly go to your plan D, that is a CICO. So you have to consider early the surgical airway. In a case of suspected or confirmed cervical spine injury, if patient is already wearing a hard collar, remove the anterior part so that it makes it easier for you. And also, no head tilt or chin lift should be given here. Always a two-handed jaw thrust for bag and mask ventilation, and manual inline stabilization. This is given by the assistant to be on the side of the patient, and patient will hold the neck and the head of the patient, while the person who at the head end will try to intubate. And also you can always expect difficult intubation here. Keep your ultrasound ready to mark the cricothyroid membrane, and if possible do an awake tracheal intubation with the fiber optic bronchoscope. Next scenario is a 60-year-old female with tongue swelling, drooling, voice changes, and progressive airway obstruction. The challenge is that the airway may disappear anytime now, and paralysis is going to worsen your obstruction and collapse your airway. So plan A will always be awake intubation because it is anticipated here. And here use a flexible bronchoscope or an awake video laryngoscopy. Anesthetize the airway and numb the patient's airways so that patient doesn't feel any discomfort, but also ask the patient to be constantly breathing. So that is maintaining your spontaneous breathing. With this you can also provide your nasal para-oxygenation and also gentle bag and mask if possible, and then you have to go for your awake surgical airway in case this fails. Next scenario, a patient with BMI 50, saturation of 82% with severe hypoxemia requires intubation. So the challenge here is rapidly desaturating patient with a difficult mask ventilation and a difficult laryngoscopy with reduced functional residual capacity. This makes it an anatomical plus physiologically challenging airway, and your plan will be an optimized RSI. Here you put the patient in a held position or a ramped up position, which is a head elevated position, or ramp is a rapid airway management position. Here you make sure the tragus of the patient is in the same line as the sternal notch, raising the head as well as the shoulder so as to maintain the oropharyngeal laryngeal axis as a straight line, which is going to aid in your first pass success. And you have to give NIV or CPAP pre-oxygenation and increase the safe apnea time in these patients, and also nasal oxygen during apnea, and use your VLS for your first pass success, and avoid repeated multiple attempts that is going to increase your mucosal edema and cause this make it more difficult. And also the second plan B will be a supraglottic airway. This iGel is going to work surprisingly well, and it is going to restore your oxygen and going to allow you another attempt at intubation, or it can also help you fiber optically guiding the intubation through the LMA. And then plan C is going to be difficult. Plan D, surgical airway, will also be difficult due to neck adiposity. You have to use your ultrasound if time permits and identify the landmarks if you are going to go for a surgical airway. Next scenario, a 70-year-old male with septic shock, lactates 8 and BP 75/40 with tachypnea and metabolic acidosis presenting to you. The challenge is that anatomy may be easy, but the physiology is dangerous, and this patient might arrest during induction. So here our plan is your hemodynamically optimized RSI. You are going to give your fluids vasopressors and prepare your push dose vasopressors. You have to give pre-oxygenation and minimize your apnea time, and you are going to carefully choose your IV induction agents. Etomidate if to make it cardiac stable, and ketamine if patient is already catecholamine depleted, avoid ketamine, or else if patient is having bradycardia and hypotension, you can go for ketamine. And then if plan A fails, supraglottic airway is also useful because that is going to allow your oxygenation. Face mask ventilation is also useful, and your plan D, surgical airway, might rarely be needed because anatomy is normal, but still it should be made immediately. The airway can be made difficult because of underestimating the complexity. If you fail to assess and if you fail to optimize, this can be the trigger that is leading to the spiral where you take multiple missteps and you fixate on a single technique instead of going for the next plan, and you lose the patient, leading it to the crisis that is the CICO and the physiological collapse, rapid desaturation. And how do you stop the spiral? You do early recognition, call for help, optimize your position, and you follow the vortex approach. The vortex approach is a cognitive aid for difficult airway management that focuses on achieving oxygenation rather than repeatedly attempting a single technique. It is it is just a cognitive aid, just is showing your plan A, plan B, plan C in the same vortex, and you take a single best attempt at each and a maximum of 3 attempts. If you fail at the plan A, you call for help and you keep your kit at the bedside ready. Then next is set, where you open your kit if the plan B fails, and you get poised to initiate your neck rescue. And if your plan C fails, you declare it as a neck rescue event, extend the neck and start your SONA. Coming to a take-home message, you choose a plan based on the attending physician's skill set, training, or available help, and be aware of the passage of time, attempts, and saturation. This is the most crucial step. And if one technique doesn't work out, try a combination or just immediately move on to the next plan, and provide and test mask ventilation after each attempt. This is also of paramount importance. And also you limit your intubation and supraglottic airway attempts to avoid your complications. Thank you. Thank you.